We welcome you after refreshing lunch. So we move on to the next session on classic session on spondyloarthritis. Our next speakers are I welcome chairpersons Dr. Krishna and Dr. Sita Nayak on stage. Dr. Kavita Krishna is from Pune. She is head of Department of Rheumatology, Bharati Vidyapit, and Dr. Sita Nayak is from Head and Dean of SGPGIMS, Lucknow. Welcome. And I also welcome Dr. Mikkel Ostgaard from Copenhagen, Denmark, and Dr. Ashok Kumar from Delhi, Clinical Director and Head Department of Rheumatology, Fortis Hospital, Delhi. Dr. Amrita Gopalan, please on stage. She is a DNB resident from Department of Rheumatology, Krishna Institute of Medical Sciences, Hyderabad. Yes. Good afternoon, sir.
Okay. So good afternoon, everyone. We welcome you all to the theme classic session on spondyloarthritis. And I request our eminent speaker, we all have heard a lot about him and a lot from him in the MRI workshops. So the keynote lecture on optimal imaging in spondyloarthropathy and psoriatic arthritis by Dr. Mikkel Ostgaard. Over to you, sir.
Forward, the pointer. Great. Like that. Right. Here.
Thank you very much for an introduction, and particularly thank you very much to Iracon for having me here. It's definitely a pleasure. And I will now speak on one of my favorite topics, which is imaging in spondyloarthritis and psoriatic arthritis. And as you all know, the spondyloarthritis is a group of diseases which share some common genetic and clinical and also imaging aspects which make them overlap in different ways. But it is different diseases, and they can be divided into different ways. If you see it from the ASIS, that's the Spondyloarthritis International Society, then you see it as on the left, where you see that ankylosing spondylitis is in the center, and that's fair enough. And then you have all the other diseases around it, including psoriatic arthritis. And that makes good sense in the actual components, where ankylosing spondylitis is definitely the key disease and having many characteristic findings. But you can also look at it in a different way, where you look at it as psoriatic arthritis as a key disease, and then look at how is the overlap there, and that is overlapping with both ankylosing spondylitis on one side, but also has similarities with rheumatoid arthritis, and that also goes for the imaging manifestations. So, but it is characteristic, you could say, if you could say that it's characteristic, that the imaging manifestations in spondyloarthritis is very diverse. There are manifestations both from peripheral joints and enthesis. There's manifestations from the spine and sacroiliac joints to varying degrees depending on which of the many diseases or several diseases that are involved. You'll see both, as you can see in this image, you'll see the psoriatic manifestations with DIP joint involvement and psoriasis, obviously, and other things that look more like rheumatoid arthritis, and you have dactylitis, and you have the arthritis mutilans in psoriatic arthritis. You may have enthesitis, as you see at the lower middle image here, for instance, in the Achilles tendon area. And you may have involvement of the sacroiliac joint, as seen in this MRI, or the bamboo spine in ankylosing spondylitis, and the appearance of AS patients there on the left. So it's a very diverse disease, and that gives challenges, or it's very diverse diseases, which give also challenges when we should select how to do imaging. And if we look at the things we can see on MRI or on imaging or ultrasound, then there is some pathologies which are seen both in rheumatoid arthritis and in particularly psoriatic arthritis, but also sometimes in the other inflammatory arthritis, such as synovitis, tenosynovitis, bone marrow edema, and bone erosions. So they are like in rheumatoid arthritis, but there are also things that we do not really see in rheumatoid arthritis, which is enthesitis and the dactylitis and soft tissue changes, as you see in subcutaneous tissue, for instance, in the sausage fingers or dactylitis, and very characteristically also the findings in the actual skeleton, being the sacroiliac joints and the spine, which are more, of course, a obligatory finding in AS or axial spondyloarthritis, but also quite frequently happens in psoriatic arthritis. And axial arthritis, axial manifestations, is actually not only the spine and sacroiliac joints, you can also have it around the anterior chest wall. So, if we look at what we can achieve by using X-rays, then the upper part here is the peripheral manifestations. And there you'll see that bone erosion and new bone formation can be visualized, and also indirectly cartilage damage by looking at joint space narrowing. While the inflammatory changes here you cannot see by X-rays. We have, on the other hand, what about the actual component? There you can see changes in the sacroiliac joints, and you can see it in the spine, but only the structural changes, and at a fairly late stage, showing the result of previous inflammation, and the inflammation you cannot see. Then ultrasound. In the peripheral joints, ultrasound is really very, very good, both in joints and enthesis actually. As you can see here with red, you can see both bone manifestations like erosions and new bone formation. You can also see the inflammatory changes in the soft tissues like synovitis, tenosynovitis, enthesitis. The only thing you cannot really see in the peripheral joints is the bone marrow edema, because ultrasound cannot look through bone and thereby cannot see inflammation inside the bone. And it cannot, there are certain locations where it can't get access to see erosions also, because it's hidden behind bone. In the sacroiliac joints and the spine, it's not really useful. Because they are really hidden, all the relative interesting manifestations, and they are mainly inside the bone. MRI has the advantage of being able to visualize all the different manifestations, both in the axial and the peripheral components, but of course has a limitation in being fairly expensive, and thereby is not always accessible. But it is an advantage that you can see all, including inside the bone and in the axial joints. If we first talk about ultrasonography, then some of the issues that, or some of the parameters that you can definitely see is the synovitis, both on grayscale ultrasonography and also with Doppler, which visualizes vascularization in the tissue, which is increased when you have when you do have inflammation. You can also see tenosynovitis. Here is a cross-sectional cut of the tendon, and you have fluid around it, and you have Doppler signal here as well. So it's very well suited for that. There's no differences in how synovitis look in psoriatic or peripheral spondyloarthritis and how it looks in RA. That's more a type of location-wise thing. Then enthesitis is incredibly important in spondyloarthritis, and that can be seen, as you see in the upper top corner here. It's more sensitive ultrasound for visualizing this than clinical examinations. And it's also sometimes seen in patients who have psoriasis who do not, you could say, have clinical psoriatic arthritis yet. If you look at enthesitis, then there's a lot of images here, and I'm not going to go through them in detail, but you see here that the tendon is inserting here on the calcaneus, and you see that the tendon has some extra additional Doppler signal here, and there's also a bursa with inflammation at this site. And there is an erosion here going down here, which also contains Doppler signal indicating that there is actual vascularization inside it. In dactylitis, that's what you see on the left. You have, you could say, several ultrasound images beside each other, and here you see that the tendon is located here, and there is some increased, you could say, mass volume of the subcutaneous tissue. And when you look with Doppler, you also see that it's more vascularized than it should be, so it is inflamed and also thickened. And that can be quite helpful. And we know that in dactylitis we'll see both tenosynovitis and soft tissue inflammation as obligatory findings, and often also synovitis. And this is just another example of the enthesitis with inflammation and Doppler signal. There has been some studies about the differential diagnostic value of ultrasound between rheumatoid arthritis and psoriatic arthritis, and not surprisingly, based on what we know about the diseases, the involvement of the enthesis and the involvement of the peritendon in areas where there's no tendon sheets is characteristic of the psoriatic or SBA disease, and not really found in rheumatoid arthritis. Actual disease, there is a few, in my view, very optimistic ultrasound articles who say that you can assess sacroiliitis by ultrasound. But it's my impression that you could say the most experienced ultrasonographers agree that that is really not the area to look for, because you can only see the very surface of the joint and not going inside and not going into the areas where the inflammation and the damage really is. But it can be helpful for, you could say, guiding injections into the sacroiliac joint in case that is something you do in your institution. But not really for anything else, because you can't look through bone. And then there is suggestions on where you should put your needle. So regarding ultrasound, then the conclusion would be that for actual involvement, it's really only relevant for guided injections. While in peripheral arthritis, it's very good actually, more sensitive than clinical examination, and as good as MRI if you have an experienced reader and good equipment, of course. It matters which machine you have, particularly for Doppler signal. It's important that you have a high quality machine. They are much more sensitive. Then regarding enthesitis, of course, that's more frequent in psoriatic arthritis and in peripheral SBA in general than it is in RA. And it's more sensitive, again, ultrasound than clinical examination. There are still some things that can be improved, particularly regarding technically and how it should be done best, particularly in those areas which are not the key ones, as for instance the Achilles tendon and plantar fascia, where we know a lot, but there's areas that could be where more knowledge could be gained by more research. Then what can we learn from MRI? In general, MRI can be used for the same purposes as ultrasound in case you have MRI more available than a good ultrasound machine and an experienced investigator. Except for the guided injections. That can be done, but that's terribly complicated with MRI. And what more can MRI give? It can give information on whether there's inflammation inside the bone or not, and then where, of course, and if there's progression in bone damage, because it can be more difficult to see that erosion has become a little bit larger on ultrasound because you don't have the three-dimensional visualization and the images are not saved from the previous time. So that's an advantage. And then the major advantage is for sure that it has the ability to monitor inflammation and damage in the actual joints. And then, so far only for research purposes, in reality is that through doing whole body MRI where you can assess the entire body in one examination, then it has the ability to assess both peripheral and actual inflammation in the same examination. What can we see in MRI? Well, you can see both synovitis here in EMCP joint, which is not a typical SPA joint, I know, but you can see it, and there you generally use contrast agent. You can see bone marrow edema as in the wrist here. You can see tenosynovitis in the finger positioned like this, where you see the tendon here and water in the tendon sheets in front of it. You can see erosions and joint space narrowing, and you can see enthesitis. I'll come back to some of these issues a little bit later. And then you can see the actual manifestations, both inflammation and damage, and I'll also come back to that a little bit later. First, I'll take a little bit about the inflammatory, the sacroiliac joint changes. When you do MRIs, you generally use water-sensitive images like this and T1 weighted images, which are very good for structural lesions. So here, water is bright, and you can see the inflammation around the sacroiliac joints and also some capsulitis here. And on the T1 weighted images, where fat is bright and water is dark, you can see both erosions and some fat infiltrations, which is characteristic of the disease. And at the same time point in this case, there is only mild sclerosis and definitely not anything that would tell you that you had actual spondyloarthritis. And thereby it shows how much time you gain in the diagnosis of actual SPA by using MRI, and that was what we discussed at length in a MRI workshop 2 days ago. So, and if you want to look at, find one paper who describes the different definitions of the SI joint changes, then this paper is fairly recent and is good. I won't go into detail with it, but just showing that it indicates there's pictures and definitions of how, for instance, bone marrow edema and other inflammatory lesions look. Also enthesitis down here, and the same is true for signs of structural damage, like what you see here: erosions, fat infiltration, new bone formation, etc. And it has been shown that MRI in the sacroiliac joint is better both for visualizing inflammation, of course, than clinical examination and X-rays, but also for visualizing structural changes than than X-rays are by comparison with computed tomography CT. There's a similar paper which has been published recently, is only available online, with definitions and image examples from the spine. And I'll show you the spine lesions in the next slide instead of here, where you'll see that there is different anatomic, difficult locations. You can have inflammation in the spine, like here in the corners where the ligaments attach, so it's an enthesitis. You can have it along the disc, like here, which you may also see in degenerative disc disease. You can have it around the costovertebral joints here. This is the rib coming in and the vertebral body where it inserts, and that is inflammation here, also seen in the sagittal slice. You can have facet joint inflammation, and you can have inflammation in the lateral components, like the ribs and the transverse processes, also because there's a lot of ligaments attaching there. Then, now this is a talk on SPA and axial SPA and also psoriatic arthritis. So what are the differences? Well, in X-rays, we know that in ankylosing spondylitis, changes are generally more symmetrical, and the syndesmophytes are more vertical and slim, as you see them here on the. Oops, where is the arrow? There it is here. That's a typical bamboo spine appearance, while in psoriatic arthritis there are often skip lesions. You have some on one side and then there's ankylosis on another side. So it looks a little bit more asymmetrical, and the syndesmophytes also takes up more volume in general than what you see in actual spondyloarthritis. That's more or less examples of the same, where you see the actual SPA appearance with the slim syndesmophytes and the more voluminous changes in actual psoriatic arthritis. And similarly, you can see that here, that it's in AS, it's you could say very slim, the appearance. And when you look at psoriatic arthritis, then the volumes also on MRI are more large and looks more, you say, it looks a little bit messy compared to what we see in actual spondyloarthritis. You can see enthesitis on MRI also, and you see here bone marrow edema nicely on MRI in this case, and almost no inflammation, and that would not necessarily be picked up by ultrasound, while this one with a high signal inside the tendon and also bursitis would definitely be picked up. So there are different ways that it can look different phenotypes. We know that in RA there is a relation between bone marrow edema and development of structural changes. That's quite clear. There's not as clear evidence in psoriatic arthritis. There's one study where it is shown that if you do have bone marrow edema in an area, then there is a higher risk to develop erosions in the same location on CT afterwards. But it's not as documented. There's much less data here than there is in RA. So I actually think I will skip this and just, in the interest of time, and just show that in the future I think that whole body MRI is quite helpful. There is, could be quite helpful, both in trials and potentially also in practice. And there is a number of different studies, and the attraction is that you can do MRI of the entire body in one examination, both examining the peripheral joints and entheses and the actual joints. Let's see if I can get this one away. I am finished very soon. So for instance, here you see a acromioclavicular inflammation here at the same time point as you have hip trochanter Meyer inflammation, and you can have changes in the spine. And you can also see changes over time. If you look at this, then there is a patient here who have inflammation in the facet joints at baseline, but it's disappeared at follow-up. And the same, there is inflammation up here in the shoulder at baseline and disappeared at follow-up. So there is a possibility for doing that. So my last slide in conclusion, regarding peripheral SPA or psoriatic arthritis, ultrasound and MRI are both very valuable for detecting inflammation and damage in joints and entheses. And ultrasound is obviously favored by being possible to do in the rheumatologist outpatient clinic, giving more feasibility in case you have the right equipment and the right examiner present at the same time point as the patient is there. While MRI can see things, you can do the images and then the examiner can do it afterwards, and thereby you don't need to be present at the time of the examination. And it allows for centralized reading if you're doing trials. And in the actual part, MRI is definitely the method of choice and more sensitive than X-ray, and ultrasound is not really helpful here. So with that, I'd like to thank you for your attention, and I look forward to answer any questions after when it's the Q&A sessions. Thank you.
So, thank you, Dr. Ostergaard. And now may I request Dr. Ashok Kumar, who is doyen of rheumatology, and everybody knows him. He needs no introduction. He's presently associated with Fortis Hospital, New Delhi, to talk on current recommendations in the management of spondyloarthritis.
Where do I make it full screen? Can you please make it full screen? Yeah, it's here. No, it's not coming down. Thank you, Dr. Naik. Good afternoon. I have been asked to speak on current recommendations on the management of spondyloarthritis. And with the limited time available, I looked at these 4 very important resource articles. And the latest one is the one on top, the ASAS EULAR recommendations, which came only last month. And you might recall in the Earth Symposium 2 days ago, what Sam Whittle said was, what is living guidelines or living recommendations? And if you go by them, any recommendation that gets published, something like 40% of them are already outmoded, because all these things took long time to decide. Things have to be updated frequently. COVID guidelines were being updated every week. And somebody asked him a question, how frequently do you think these guidelines should be updated? He said 3 months. So this one is very fresh, last month only. So I think it is still living. And we should focus on this first, and then I will talk about whatever differences exist between EULAR and ACR. Now, this is the publication that came last month. Now, here they have the usual format of overarching principles and recommendations proper. So here there are 5 overarching principles, in which the first one emphasizes that a multidisciplinary approach is required to this condition, where rheumatologists are at the center and other specialists chip in. The second overarching principle is that the primary goal of treatment is to maximize health-related quality of life by control of inflammation and prevention of structural damage and all. The third is that optimal management has to comprise of 2 major things, pharmacological as well as non-pharmacological management. Both are very important. And the fourth one is that the treatment should be the best and based upon shared decision making. So shared decision making is very important between the patient and the rheumatologist. And lastly, the treatment has to be cost sensitive, because huge costs are involved sometimes. So you must take into account what is sensible to do. And these are the 15 recommendations. You don't have to read these, but I'll go through each one of them on each slide. So the first recommendation is that the treatment of patients with axial spondyloarthritis should be individualized and focus on current signs and symptoms of the disease, which might be axial, peripheral, or predominantly extramusculoskeletal manifestations, EMMs, as well as take into account the patient characteristics, including comorbidities and psychosocial factors. So my comment will be that the EMMs, we all know, include IBD, that is inflammatory bowel disease, psoriasis, and uveitis. And the comorbidities, the 2 topmost comorbidities in this condition are osteoporosis and cardiovascular disease risk. Second recommendation is about the disease monitoring. And what they have said is, disease monitoring should include patient-reported outcomes, clinical findings, laboratory tests, and imaging, all with appropriate instruments which have been validated and relevant to the clinical presentation. And the frequency can be decided depending on the individual. Now, my brief comment on this will be that AS-DAS has emerged as the most appropriate measure, composite measure of disease activity as of today. BASDA is definitely inferior. Another index which has been validated and popularized by ASAS is ASAS Health Index. It's a good measure of function and as well as overall health of the patient. MRI is not recommended as a monitoring test. And structural damage can be monitored with radiographs repeated at not less than 2-year intervals if needed. However, ACR is not in agreement with this viewpoint. And this is the cutoff points of ASDAS, which define inactive disease, low disease activity, high disease activity, and very high disease activity. I will not go into more detail. And this is the health index, ASAS health index, where you have 17 questions and answer is yes or no. Every yes scores a point of 1, so total score is 17. Higher the score, worse the patient's health. And third recommendation is treatment should be according to a predefined treatment target. Now, my comment on this is that the main trigger for this treat to target business arose from a study which showed that more ASDAS means more syndesmophytes. So a tight control of spondyloarthritis TICOSPA trial was done. Unfortunately, did not achieve its primary endpoint of 30% improvement in ASAS health index. However, some secondary outcomes did improve. The effectiveness of treat to target remains unproven as of today, and therefore ACR doesn't support this controversial recommendation. The fourth recommendation is that patients should be educated about axial SPA and encouraged to exercise on a regular basis. They should be advised to stop smoking, and physiotherapy should be considered as an important part of it. Now, there is no doubt that physiotherapy is a cornerstone of treatment here, but there is some uncertainty about the most effective exercise program for axial SPA. But it is known that supervised group physical therapy is the best, and it is better than home exercise program, and which is better than no exercise at all. Fifth recommendation says that patients suffering from pain and stiffness, the first line treatment is NSAID, up to a maximum dose, taking risks and benefits into account in an individual case. For patients who respond well to NSAIDs, continuous use is preferred if needed for full control of symptoms. Now here my comment is that continuous use of NSAIDs is required mainly for control of symptoms. The previous controversy that it prevents structural progression is now resolved. A meta-analysis of 8 studies in 2020 has established there is no prevention of structural damage, and so don't use it for that purpose. NSAIDs achieve disease control in half the patients. You consider them a failure only if 2 NSAIDs have been tried over 2 to 4 weeks without any benefit. The sixth recommendation is that analgesics also have a role, but this is an expert opinion only. Patients who continue to have pain despite all your efforts. It's an expert opinion. There is lack of trials on analgesics in axial SPA, and there is a risk of addiction as well. Seventh recommendation, glucocorticoid injections are directed into the local site of musculoskeletal inflammation may be considered. Patients with axial disease should not receive long-term steroids at any cost. Now, ultrasound-guided steroid injections into sacroiliac joints are a routine thing, into a peripheral joint also, established practice. But short-term use of systemic steroids we all do, and this is acceptable. Long-term not. Eighth recommendation is that patients with purely axial disease should normally not be treated with conventional synthetic DMARDs. This is what ASAS-ULAR recommendation says. Sulfasalazine may be considered mainly in patients with peripheral arthritis. You know that ACR also recommends the same thing about sulfasalazine. But they consider methotrexate completely inefficacious even in combination with TNF inhibitor. However, studies from India have shown, Shifali Khanna and Debashish both have done their studies and published, that there is some efficacy of sulfasalazine as well as methotrexate even in axial disease. They have used combination as well. And many of us are using conventional synthetic DMARDs even now, based on our conviction that it works in 35 to 40% of patients, and all our patients are not able to afford biologics or other expensive drugs. The ninth recommendation is that TNF inhibitors, IL-17 inhibitors, or JAK inhibitors should be considered in patients with persistently high disease activity despite conventional treatments. The current practice is to start TNF inhibitor or IL-17 inhibitor. That's what ULAR says. Now, my comment is that persistently high disease activity, first of all, is defined as AS- more than or equal to 2.1 despite 2 NSAIDs over 4 weeks with or without conventional DMARDs. Now, TNF inhibitor and IL-17 inhibitor are the current practice, not JAK inhibitor. It's not clear if the major cardiovascular adverse events and cancer concerns of JAK inhibitors which have been seen in RA will apply to axial SPA because the population is much younger. Increased CRP and inflammation on MRI of SI joints predict good response to TNF inhibitors. And for non-radiographic axial SPA, FDA has approved only certolizumab. Biosimilar TNF inhibitors we all favor because of the lower costs. 10th recommendation is that if there is a history of recurrent uveitis or active IBD, preference should be given to monoclonal antibody TNF inhibitors. In patients with significant psoriasis, of course, IL-17 inhibitor is the choice. Why? Because monoclonal antibodies are more efficacious in preventing uveitis than etanercept or secukinumab. They are also preferred in inflammatory bowel disease. IL-17 inhibitor is, of course, preferred in, is contraindicated in IBD. The 11th recommendation says that absence of response to treatment should not elicit a knee-jerk reaction to straight, another immunosuppressive. They would like you to re-evaluate the diagnosis and consider presence of comorbidities. Now, comorbidities may be contributing to failure of response, and these prominently include fibromyalgia, osteoarthritis, and depression. The 12th recommendation is that following first biologic or targeted synthetic DMARD failure, switching to another biological DMARD or IL-17 inhibitor or TNF or a JAK inhibitor should be considered. Now, the second TNF inhibitor can still be efficacious in TNF inadequate responders, although with lower efficacy. But ACR recommends IL-17 inhibitor over a second TNF inhibitor. So here there is a difference in recommendation. The 13th recommendation is if the patient is in sustained remission, tapering of biological DMARD may be considered. Now, sustained remission is defined as AS- less than 1.3 for 6 or more months. Tapering is done by spacing out the injections basically, and tapering is applicable to TNF inhibitors only. ACR does not favor tapering of biological DMARDs at all. So here is a major difference. We know all of us try to taper it because, first of all, the economic reason, second, the risk of infections if you continue. Now, the 14th recommendation, there are indications for total hip arthroplasty and corrective osteotomy in appropriate cases. These may be carried out. 15th recommendation is that if a significant change in the patient's status occurs in its course and causes other than inflammation such as spinal fracture also should be considered seriously and ruled out. Appropriate treatment should be carried out. So the last two slides are just the algorithm. Have I finished my time? If you have 1 or 2 minutes, I can just go through this algorithm, but basically a repetition of the same. So if you have a patient with a diagnosis of axial SPA, you offer physiotherapy and education about the disease and recommendation for regular exercises and stopping smoking to all patients. Start NSAIDs and titrate up to the maximum tolerated dose. And if sufficient response occurs, just continue it. If not, make sure that you are given 2 NSAIDs over 2 to 4 weeks. And still, if there is no response, patient enters the second phase. In the second phase, you consider whether patient has predominantly peripheral disease or axial disease. If it is peripheral disease, according to EULAR, you can use local glucocorticoid injections. You can give a trial of sulfasalazine. If it is predominantly axial disease, then of course you consider TNF inhibitors or IL-17 inhibitors or JAK inhibitors, but current practice prefers the first two. And with this treatment, if the improvement of AS- is 1.1 or greater, then it means it's a good response, you continue, and if after 6 months remission is sustained, consider tapering. And if this is not working, then patient enters the third phase, and third phase in the lower half of this slide. So you re-evaluate the diagnosis, consider other comorbidities, and if you still confirm this is active SPA only, then of course you go for another biological DMARD or a JAK inhibitor. And if this works, you continue for 6 months. If remission is sustained, consider tapering. If not, then keep trying the other alternative. So I'll end here, and take any questions. Thank you.
Thank you, speakers. The house is open to questions from the audience. Okay, so I'll start the questions. Oh yeah, okay, sure. Yeah, please, yeah.
So as per the recommendations, we start the anti-TNF only if the patient is NSAID failure. So we give NSAID for about 4 weeks and switch over to another NSAID and see whether that also works, and that fails, then we go for anti-TNF. So I think the implication is that if the patient is responding, how long should we continue the NSAID? I mean, is it like we continue it indefinitely, or how is it possible, how feasible is it in our practice to recommend a continuation of NSAID to our patients?
You see, what they have said is that you can continue NSAID. They have not specified the duration, but we know very well that after a certain period, side effects might appear, and you have to watch out for that. An individual case may be more prone to get side effects, so you will have to put your own, ceiling there, and then opt for the next option. So you can't just put a patient on NSAID blindly and just not even follow up. You have to keep a close follow-up.
Next question.
Sir, we do not talk about the osteoporosis associated with spinal inflammation in any of the recommendations. Do you think
you want to ask about how you manage osteoporosis in spondyloarthritis?
In spondyloarthritis?
Well, it will not be different. I mean, it is mostly spinal osteoporosis because of the immobilization. And even detecting osteoporosis can be a problem because they have syndesmophytes and all, and your DEXA might give spuriously normal or even higher scores, T-scores. So in this situation, you have option of doing lateral DEXA, where you remove the, posterior elements, and that might give you the correct picture. Or you may do a quantitative CT, which is imparting a lot of radiation. So that's not really a great option. But lateral DEXA I have often tried and got some idea of how much osteoporosis is there. But if somebody has had a bamboo spine, obviously it has been there for a long time. You can take it for granted it is a hollow spine, it has got severe osteoporosis within, and the osteoporosis will have to be treated. So you can choose the agent according to what you do in other cases of osteoporosis.
Yeah, your question please.
Sir, what is the role of phenylbutazone? Whether it should be preferred over other NSAIDs?
No, I didn't get your question.
What is the role of phenylbutazone? Whether it should be preferred, phenylbutazone.
Phenylbutazone.
Yeah,
I
it
don't
should
know
be.
If anybody uses phenylbutazone these days, is it available?
Sir, it is available. Oh. It is still available.
I thought it is gone.
Yeah.
No, I would not give it. Yeah. Certainly not. There was a time when we had no option but to use phenylbutazone, but in the current practice, phenylbutazone is not recommended.
Sir, Dr. Roy from Hyderabad.
May I ask it's available in USA. It has been written by 2 rheumatologists by FDA approval guidelines. Unless 2 rheumatologists writes, they don't. Pharmacy doesn't give. It is a restricted drug. India, I don't think it's available, sir.
It's not available
because drug control of India banned long back. Because Stevens-Johnson syndrome and death was very high with phenylbutazone. I think in 1990 it was banned.
So it is still manufacturing in Gujarat, in the Ahmedabad company.
May I ask a question?
Thank you.
My name is Kaushik.
Yeah, one question.
I think I was in Dr. Ian Roy from Hyderabad.
Your mic is not working.
So can you hear me?
I think I'm standing behind the camera, so.
Just speak a little louder.
Yes, sir. Did you encounter a case of overlap SLE with ankylosing spondylitis?
Overlap SLE with?
Ankylosing spondylitis.
Not really, no.
And how would you treat such a case?
I've never seen, but
it is there in the documented in the journals, and I have personally have one case.
Well, I mean, if you have to treat and whatever SLE requires for treatment, you will go ahead.
Mainly for the eggshell symptoms, the patient is not responding to NSAIDs, then how do you proceed?
Okay, you want to say that you can't use TNF inhibitor, so that will be a limiting factor. You will use secukinumab. You can use JAK inhibitor.
Dr. Ashok, from NIMS we reported 4 cases of Angstrom with SLE. I treat them as a concomitant diseases. Then because genetics of both are different, frontal cytokines both are different, there are not many core data, but case reports are there. You treat SLE like SLE, Angstrom. Because both the treatment regimes are different, algorithms are different. I feel we treat as a concomitant diseases, nothing to do. 2 autoimmune diseases coexisting.
Professor Kumar, can I ask a question? I'm standing behind the cameraman, so I'm not visible.
Okay.
My name is Kaushik Bhojani. Professor Kumar, this was in connection with 3 questions ago. Somebody spoke about the DEXA and you suggested a lateral DEXA. Lateral DEXA software is not available in most places, but I was wondering about your experience. I've been using quantitative CT bone densitometry for ankylosing spondylitis, because then you really don't have to worry about the calcified ligaments coming in the way and giving you a false reading. And a quantitative bone CT is my preferred method, but I just thought if you have some comments on it.
Quantitative CT will provide a lot of radiation to the patient, and that may not be a good idea, because you will have to repeat it also later, isn't it? How will you monitor?
Hello. Just like we have the DEXA scans being done possibly 2 yearly, is the way we would be doing a quantitative CT. The amount of radiation required for a quantitative CT is less than that of an HR CT that we do before we start biologics. And hence, I don't know, it would be feasible. The newer softwares with quantitative CT also give you the hip joint bone density, which the earlier ones didn't have. And the amount of radiation I've kind of looked at, and it doesn't work out to too much because you're going to do it biannually.
That's good information.
Thank you, Dr. Bhojani. I just have one question for Dr. Mikkel. Others can ask Dr. Ashok later. So, sir, in distal interphalangeal joint involvement in psoriatic versus osteoarthritis, so would imaging help you in distinguishing the DIP joint involvement?
Thank you. So DIP involvement, it does help, but it doesn't solve all the problems, honestly, because you can see that the amount of inflammation you see in psoriatic arthritis is more pronounced than it is in OA, but you also see some inflammation. So if there's severe inflammation, it points definitely through psoriatic arthritis, and also some of the interstitial inflammation you can see if you're a very high resolution MRI will help you in distinguishing. But I'm not saying that it's easy, and it depends a lot on the quality of the MRIs because it's very small joints. So if you have very good MRIs, then you can see the entices and the tendons there well, and if not, it's more challenging.